Uh, my name is my name is Chanda Freeman. I am the Health Policy and Advocacy Manager for the Tennessee Justice Center, and we are absolutely honored that you have decided to join us tonight as we celebrate Black Maternal Health Week with this webinar from the fabulous Dr. Karen Scott. The webinar is entitled Addressing Obstetric Patient Safety in U.S. Birthing Hospitals. And just a quick overview of what to expect tonight. This webinar should last for about 1.5 hours. Just an overview of what we're going to talk about. We'll hear about limitations in the existing obstetric quality and patient safety paradigm. We're going to hear a little bit about the difference between being safe versus feeling safe. We're going to list patient and community defined and driven strategies that address obstetric racism and advance obstetric patient safety. So a little bit about the Tennessee Justice Center. We are a nonprofit organization here in the state of Tennessee that's around 28 years old. We provide clients individual representation regarding healthcare and nutrition programs. Our organization uses the power of the law to correct systemic issues. And we also advocate for legislative and administrative changes on both the state and federal level. And again, thank you for joining this webinar. And now I'm going to toss it on to Nick, who's going to introduce our speaker.
Yeah, and again, welcome everybody. Thank you for joining us tonight. My name is Nick Rummel, and I am a health advocacy and policy intern with Tennessee Justice Center. And I have the pleasure of introducing our speaker tonight. So with us tonight is Dr. Karen Scott, MD, MPH, FACOG. And Dr. Scott proudly stands as the Chief Black Feminist Physician Scientist, founding CEO, and owner of Birthing Cultural Rigor, LLC, boasting a remarkable legacy of service, leadership, teaching, mentorship, collaborations, activism, and advocacy spanning over 25 years. Dr. Scott's unwavering commitment unveils a critical exploration of health services, design, provision, evaluation, and training in obstetric units as arenas perpetuating obstetric racism against Black women, girls, and gender-expansive individuals, with the power and potential to better serve, protect, and care for our Black communities with dignity and grace. And with that, I just want to say I'm so excited to hear Dr. Scott talk tonight. I'm going to turn it over to her and let her impart us with all of her wisdom. So Dr. Scott, thank you again, and I'll turn it over to you.
Thank you, Nick. Thank you, Shanda. Thank you, Thomas. Thank you, the Tennessee Justice Center. Thank you, everyone, for joining us on the 7th day and final day of the 7th annual Black Maternal Health Week that was first established by the Black Mamas Matter Alliance in 2017, where our Black Maternal Health Week for 2024 theme is Our Bodies Still Belong to Us, Reproductive Justice Now. So I will go ahead and begin to share my screen and we can get the conversation going about tonight's talk. Okay, so we'll be talking about addressing obstetric patient safety in U.S. hospitals. As Shanda was saying, our learning objectives are to define the limitations in the existing obstetric patient safety and quality paradigm, to be able to explain the difference between being safe as defined by systems and structures versus feeling safe as defined by patient experiences and community wisdom, to name and define at least 2 Black woman-defined theoretical frameworks for contextualizing this manufactured Black maternal health crisis in our country, and then to be able to list patient and community-defined and driven strategies to address obstetric racism and to advance obstetric patient safety. So a little bit about myself, a little bit more about myself. I became a physician so the world would listen to a Black girl born at Hubbard Hospital, whose mother, sisters, and myself navigated life in East Nashville CWA apartments on South Fifth Street in the late 1970s and early 1980s. So yes, I am a native Nashvilleian. I left in 94 and then I came back the fall, winter of 2021, so about 30 years later. And all I really wanted to do, honestly, when I entered college was to actually pursue my PhD in molecular biology and to crack the genetic code. And then I got introduced to Billie Avery and the tremendous work she was doing in both Florida and Georgia, and essentially addressing the systemic and structural racism, classism, sexism, exploitation, just the harms and violence enacted against the reproducing Black body by all of these systems. And so that inspired me to change, I would say like a course correct, change my trajectory so that I could become a physician, not so that I could be at the bedside. Really, I wanted to transform models of care delivered to women and girls, particularly Black women and girls who reminded me of my family and my community in East Nashville. I earned my MD to acquire authority and autonomy to affect change. So then by 20, my mission was to transform healthcare delivery models for Black women and girls. So yes, I grew up in East Nashville before gentrification. I am the daughter of Edith W. Floyd from Tennessee and the late John Henry Scott Sr. from South Carolina. I am very grateful for the gift of a formal liberal arts education from fifth grade Meg's Magnet School here until high school at Hume Fogg, all the way to medical school at Case Western. And all of those are really grounded in a liberal arts education. So I firmly believe in being, thinking, and doing as a lifelong learner. This is the way. I'm a very proud Black feminist, reproductive justice avenger, a Wakanda healer, a Yoda follower, a Care Bear hugger, a public health scholar, a dissident and recovering OBGYN, applied epidemiologist, and a health systems disruptor, transformer, and architect. Is this my 21st year? I'm thinking, yes, this is my 21st year. No, 22nd anniversary celebration as a community-based trained and serving OBGYN. And right now, my passion and purpose is to advance cultural rigor, which those two words are the combination of scientific rigor defined by the National Institutes of Health and cultural humility defined by Dr. Dennis Murray Garcia. And why am I blanking on the other physician's name? Millie Tervalan. Through the operationalization of Black feminism, reproductive justice, and research justice in participatory quality improvement and implementation science, practice, and research, and interprofessional education and training. So that's me. So if you don't remember anything else about tonight's kind of webinar, I implore you to not leave the 98 behind and make hospital births safe. And where does that come from? Well, in the United States, 84% of pregnancy-related deaths are preventable and predictable and unfair. Did you also know that 88% of the births are attended by physicians? So this misinformation, kind of negative talk around safety and birthing with midwives is actually untrue, because right now it's the reverse. There was a while ago in the 18th, 19th century where midwives birthed this nation, particularly Black Indigenous midwives, the grand midwives. And because of the professionalization, medicalization, commodification of birth and bodies, reproducing bodies, particularly Black reproducing bodies, physicians, white male OBGYNs, and white public health nurses conspire to almost nearly eradicate Black grand midwives. So now we have the reverse, where midwives are having to face structural and systemic oppressions and barriers to go back to the place where they were already birthing the nation, when we actually were birthing it with safety and with dignity. Now 88% of the births are attended by physicians. And so if 88% of the births are attended by physicians and 84% of the pregnancy-related deaths are preventable, then the onus is really on modifying physician behavior, not midwifery behavior. And I'm a huge proponent of birthing at home or in a community in a birthing center. And the group that has activated their autonomy, their free will, their agency, the power to make a decision, the demographic that is activating their autonomy and agency to birth outside of a hospital, at home, or in community are Black women. And that increase has occurred in the last 4 years. And in spite of that increase and representing that 2% of people birthing outside the hospital, 98% of folks still birth inside of a hospital. So even after you leave the hospital, right, and we've talked about that the 84% of pregnancy-related deaths are preventable, 53% of the births are occurring actually between postpartum day 1 and 365. So as we continue to invest, right, in midwifery care and birthing at home and birth centers, let's not leave the 98 behind. And that's important because we got to make birthing in hospitals safe. I was going to say safer, but really it's just safe. And the vision that we have for birthing in hospital settings is influenced by an adaptation of sex positivity, as well as Black Women Birthing Justice, the book that I read in 2017 and also taught, where I realized I was trained as a physician, as an OBGYN physician, to not necessarily support the sanctity of birth, but to monitor and manage birth. And that's a very different thing than situating your mind, right, and your attitude and your language and behavior to activate, to amplify the sanctity of birth. So for our organization, the work that we do, here's our vision for sacred birth for Black mothers and birthing people. So sacred birth is a radical attitude towards human births, specifically Blackness, Black bodies, and Black births that regards all birth activities as fundamentally normal, healthy, spiritual, familial, magical, transformative, erotic, communal, emancipatory, and power activating. The reason why I say emancipatory is that when Africans arrived in this country, right, through slavery as an enslaved person, we were birthing in slavery. So we are now need to be, right, able to birth, right, and be able to experience an emancipated birth. And to have our power not be given to us because we innately already have power, but to have that power be acknowledged, affirmed, activated, and amplified. So sacred birth encourages diverse and inclusive birth pleasure, practices care, spaces, options, partners, communities, and experiences. Sacred birth movement advocates for safer, respectful, dignified, high quality, participatory birth care, conditions, experiences, and outcomes, as well as an improved workforce diversification, development, sustainability, and restoration of Black midwifery care and Black doula support as part of its campaign. So in thinking about, right, this emancipated birth, this sacred birth, making hospital births safe, and that 84% of the pregnancy-related deaths are preventable, and 88% of births in this country are attended by physicians, we really, again, need to be transforming the way birth care is provided in our country. And one of the reasons why we have a problem with getting to a safe birth is actually the ways in which we evaluate birth. So again, if you don't remember anything else, don't forget about the 98. And the second thing is, don't conflate a positive outcome with a positive experience. And what does that mean? On this slide, you'll see a beautiful picture of a Black mother and a Black baby and a list of positive outcomes in which we've used to evaluate a hospital's performance. And so we've said that a birth is safe in this country if it's a full-term pregnancy. You get to 37 weeks pregnancy age or greater. You have the absence, right, of medical conditions, comorbidities. You optimize prenatal care. You start early and go to all the visits that are determined by the week that you start the care. That you have a vaginal birth. And in the event that that area in the vulvar vaginal area has a little tear, which can happen during birth, it's repaired with no complications. You have a normal weight infant, and that infant is healthy. There is no need for any intensive high resource care, like in the neonatal intensive care unit. The infant latches well to the breast, chest, or body. If you have these outcomes, that hospital and that birth are labeled high performing, high quality, and safe. But at the bottom, when I did ask a Black mother in 2019 about this very birth experience, she had all these positive outcomes. So the room, she was saying, everyone was like high-fiving, celebrating. But to her, she reflected on her experience and what she shared with me about her experience and about how she feels. Though he put me back together, I still don't feel whole. So this is an example of how you can have a safe birth based on positive outcomes, but a person still feels not whole. They feel degraded, they feel dehumanized, they feel dismissed. So in fact, is this truly a safe birth or is it an unsafe birth? Though he put me back together, I still don't feel whole. We have to think about the ways in which we are measuring, right? The way we are defining safety. So traditionally, we look at these outcome measures to evaluate hospital performance, but in reality, in this table that I'm showing you, right, the traditions on the left, the system's intention, right, is to evaluate the hospital performance. But the reality in the middle column, the impact on the community is that we're actually really evaluating the performance of the body. And in this particular case, the reproducing Black body in birth, where that body has endured generations, right, of structural systemic oppressions, forced sterilizations, forced rape, forced birth, forced partnering, um, all of the structural and social determinants of health around housing, food apartheid, housing apartheid, even with labor, right? Black women are the most educated demographic in our country. But when we look at that compensation for being so educated, we're actually not making a lot of money. So we have all those things going on across generations. Looking at the performance of our body should not be a way to evaluate the performance of the hospital. We should be we should be evaluating the performance of the hospital and the language and behavior that comes out of their bodies, right? As individuals or as teams or as units, departments, as systems, as an institution. So the recommendation on the right of that table is if we were to think about being innovative and disruptive at the same time, we really should be thinking about experience measures, how an experience measure can evaluate hospital treatment or mistreatment of anyone giving birth, particularly Black mothers and birthing people. And if we were to emphasize the experience, then we would see how this person who had a list of positive outcomes had a horrific experience because she didn't feel whole in her care despite all these positive outcomes. And here's a narrative from my 2019 research to just demonstrate how you can have all these check boxes, right? The positive outcomes, and still be dismissed, discarded, disrespected, and degraded.
The biggest issue I had with my labor and delivery experience is the fact that I developed a birthing plan in writing prior to delivery that was in my chart regarding pain control, yet it was not honored. I expressed my need and want for an epidural to anyone who would listen. They cared for me during my time at the hospital, yet somehow I was forced to deliver naturally without any pain medication. This was not because I had a quick labor either. I got to the hospital at 7 p.m. They started my induction at about 10 p.m., and I did not deliver until 6:06 a.m. So they had ample amount of time to fulfill my need for an epidural. There was a point where my husband was asleep and I could not yell loud enough to wake him due to the amount of pain I was in, but I could reach the nurse's button, but nobody would respond. I felt like I was in pure hell, and it was the worst, most painful, most traumatic experience I had to endure when it comes to labor and delivery, and this is my fourth child.
So this Black mother is a pro. She's what we call a multiparous woman. She's given birth 4 different times. And for her, if someone were to look at her chart or a checklist of equity, right, of safety, they would actually say she had a safe birth. They would also tell her she should be glad she survived. Well, survival is not our goal. Thriving is our goal. Having humane, just, and dignifying experiences are our goal. So along the same lines, now I've been saying this for about 6 years. So along the same lines, April 11, 2024, the first day of Black Maternal Health Week, US News and World Report releases this article here on the left, and it lists 26 hospitals that they deem to be great, right? They deem these hospitals to be worthy of recognition for having excellent Black patient outcomes. And in this article, the outcome was defined as reducing the cesarean birth rate and having lower neonatal complications. But just the same way that you just heard this Black mother who had all these positive outcomes share how her birth plan was discarded, how her pain was ignored, how people lacked empathy for her suffering and lacked motivation to end her suffering. That is not a safe birth. And that should not be an indicator of excellence in a hospital setting. So again, we have to interrogate positive outcomes and positive experiences. We have to interrogate the perinatal quality improvement lie, right? That says on the right, the absence of perinatal pathology is the presence of perinatal equity, because that's what we're doing. We are investing in strategies and in initiatives to decrease the rate of adverse outcomes without evaluating the experience of care as defined for, by, and with the patients, right, who are carrying the greatest burden of harm, and the communities around them that are actually intervening on behalf of the patients within the hospital setting. That's how we really should be defining what safety is. And then that is how hospitals should be truly evaluated. By limiting safety to only the absence of physical injury or the reduction in adverse outcomes, we have a myopic, very limited, really false perspective of quality and safety in hospital settings. Which goes to why my colleagues and I wrote this article. Emotional safety is patient safety. This got released let's just say, I think 2023, last year in April. And what we did in that article, this editorial that it was published in BMJ, the British Medical Journal, Quality and Safety, which is one of the top ranking, if not number one ranking journal in the world on quality and safety, we were able to justify the need for a new patient safety paradigm using obstetric racism as the exemplar. And I'll go into more detail about what obstetric racism is. But in this paper, we were able to talk about that the motivation towards being safe, or safe is defined by systems and structures, quality and patient safety professionals, that we're essentially allowing the system to determine how safe it can be based on itself, meaning there is no accountability outside of itself, right? There's no opportunity to see how the system defining itself as safe and evaluating itself as safe, and then being also part of the system, if we include insurance companies, to say, oh, this is safety, you all should be reimbursed by the safety mechanism. All these forces are erasing or excluding the actual experience of harm that's happening to patients and their communities. So what we do is we we demonstrate that we don't believe in the feelings and experiences and the wisdom of patients and community, and helping us to create what safety means, helping us to give not only meaning to safety, but to develop the measurements of safety. And when we do that, we do create harm. So the entire article was showing the different limitations, right, of prioritizing being safe over feeling safe. And what are those consequences? There are just 4 key consequences that occur when we prioritize being safe as defined by the system over feeling safe as defined by patient experiences and community wisdom. And these 4 consequences on the slide are: number 1, we end up dismissing patient feelings and testimonies as real outcomes. Number 2, we end up diminishing the value of patient testimonies and positioning patient testimonies as subjective truths that lack objectivity and credibility. 3, we end up displacing the onus of responsibility, recognition, reporting, repair, and reconciliation from the system to the patients or the patient provider dyad or the healthcare hospital team, right? We're actually not putting the onus on the system or structures that have gotten us here in this manufactured crisis. And the fourth thing is we are denying the possibility, right? The possibility through imagination, innovation, disruption, and transformation of patient safety beyond the absence of physical injury or reduction in the rate of adverse outcomes. We are downgrading patient safety meanings, measures, and monitoring strategies. So this is a quote from me from the Washington Post, essentially, again, saying the same thing. Just because you don't see the pathology that you define doesn't mean someone's not being hurt or harmed. So it's very, very important that we not only look at outcome measures, but we complement those outcome measures with experience measures to get kind of a more robust or more rigorous or more relevant, more accurate and more precise understanding of what safety is, like right, the actual impact of safety versus the intent of safety. So in thinking about, again, safety, Moya Bailey she coined the phrase misogynoir. And that's very important because the words on this screen are some of the words that our providers actually use in the health record. So misogynoir is the ways in which in the media, but also in any sector in society, particularly in the healthcare field, we demonstrate our hatred of, our contempt for, and our prejudice against Black women, anti-Black misogyny. And that occurs in that first kind of bucket of words. There's actually a theory where, particularly in the epigenetics world, and sometimes in public health, where we say that we blame or we blame the outcomes of the infant or the fetus or the baby on the behavior of the mother. And we do allow that mother blaming in maternal child health, where we say that if a Black woman is older, fatter, or sicker, that's the reason why she and her baby are experiencing these horrific outcomes, right? As opposed to the system and structures, right, are not providing optimal care to this Black mother and her baby. And the other words on the screen, we also see in the health record. We see unfit, untrustworthy, irresponsible. If a Black mother person asserts themselves, right, and demands more information, they want to delay following through on a recommendation or procedure, or they have the right to just refuse, we end up saying that they're angry, or they're non-compliant, or they're aggressive, or they're intimidating. So this is an example of misogynoir that has happened in the visual culture and digital spaces, but it also happens, right, in the documentation and dissemination of healthcare information, in the health record, in the patient sign out, and in the handoffs. So the reinforcement and reproduction, right, of these anti-Black racist, anti-Black sexist, or anti-Black misogynistic words, right, that occur are reinforcing stereotypes that go all the way back to chattel slavery and the antebellum era, which I won't go into detail, but those stereotypes come alive, right, in our communications, in our interactions, in our counseling, in our decision-making, again, in the health record, and how we exchange information about the patient with providers, to the point that we create a script, right, about the story of this patient, so that health teams are not actually meeting the patient, they're meeting the health record. And we think about the power of the health record, right, in shaping our attitudes, our language, and our behavior, our response to the patient. It's very reminiscent of the felonies record, how that follows somebody and creates burdens and barriers for them to optimally show up in society, right? If we believe they've been rehabilitated. So if we are seeing patients and believe there's change, but we're writing in the chart in ways that reproduce misogynoir, we are contributing to the harm. And that is a form of safety that we're not actually including, right, in the quality of care, patients don't even get to rewrite their narrative in their health record, which goes to this study. Testimonial injustice, linguistic bias in the medical records of Black patients as one group and then as women. And the point of this study was that it looked at different types of linguistic or language producing systems of communication used by physicians to show that they doubt or disbelieve patient narratives of their lived experience, which is what we call testimonial injustice. And they also explored these racialized and gender differences in the use of language. So there is a behavior around documentation where folks will use kind of quotation marks, or they'll use judgment words such as claims or insist to suggest doubt, or they'll use some forms of things that the physician will define as the evidence to show that they don't actually believe what the patient is saying. And so they looked at the language in the chart for the study, and in this study where 74% of the patients identified as Black and over about 60% identified as female, they found that physicians were more likely to write about Black patients compared to white patients using one of these kind of quotes, using at least one judgment, and all these evidentials of writing the patient's narrative in a way that the patient was describing the phenomenon in their body as like hearsay and gossip, as opposed to believing what the patient says about their body. The ways in which we've been trained to even write in the chart is subjective, what the patient says, and then objective, what we do, right, to either confirm or negate what patients are saying through the evidence that we use, whether it's through technology, labs, imaging, physical exam. But the fact that we are organizing the patient's reported experience of what's happening in their body in this way, right, reinforces that we actually are playing, whether we meant to or not, a role in perpetuating testimonial injustice. And when we do that, right, when we doubt, dismiss, undermine what patients are saying, we are also doing that not only to like patients as experts, but to Black women as scholars, as content and community experts. The production of knowledge then becomes siloed to one group of people that we've stated only have the right to think, and then we have the right to share their thoughts, and then only have the right to have those thoughts be believed as fact, as truth, as a body of knowledge, the epistemology of something. So when we are silencing Black women or keeping them silent in the maternal child health field, particularly, right, our over-reliance on data from diseased or dead Black women, we have this hypervisibility of Black women as victims and not as victors, not as autonomous, right, agents in creating the knowledge about the experience of what's happening in their body. We also have this structural exclusion and erasure of Black women, as I was saying, as patient, community, and content experts. And then we have this control, this constraint, this censorship of Black women's narratives and intellectual thoughts. So we not only are not believing the individual, but we collectively now don't believe a group of people and what they say is happening to them in their body, right, in the hands of the system. And we also do things so that people don't even believe them when they do speak their truth. That's all hermeneutical injustice, which gets us to this slide. So all the things that I'm talking about, the whole dismissing, diminishing, degrading, all of it is impacting the knowledge that we produce in the evaluation of care. So that's epistemic redlining, that's epistemic injustice. All those injustices are around being a producer of knowledge and having other people believe the knowledge that you are producing, particularly when it's about things happening in your body. So hospitals in the United States do not routinely keep Black women, girls, and gender expansive people and their loved ones safe during pregnancy, labor, birth, and postpartum. And the work that I do is that I look at that persistent near gap or death gap, and I contextualize that with Black women defined theories. So reproductive and perinatal apartheid is what I defined as an adaptation of Harriet Washington's medical apartheid. And this essentially is just all the policies and practices at the local, state, regional, national level, right, that determine the distribution, right, of the social determinants of health: housing, labor, food, promotion, advancement, income, wealth. All of those things impact the ways that we have options and then choices around our pursuit of life, liberty, and happiness. There's also the Sojourner syndrome by the late Dr. Leith Mullins, an anthropologist. Which I love about the Sojourner syndrome is that it looks at intersectional oppressions of racism, sexism, and gender oppression, class exploitation, and looks at those three things simultaneously and how, again, they structure our access to health care. And they do that for both Black men and Black women, but then they also look at that in sexual, reproductive, and perinatal health. Not only does Leith Mullins look at intersectional oppression, but the Sojourner syndrome also looks at community acts of resistance and resilience. So it's a framework that looks at the ugly, but also looks at the beauty and power in communities as we navigate these systems to get what we need when these systems and structures no longer serve us. And then there's obstetric racism, which I will define later. But I contextualize these things because it brings in history, it brings in the social sciences, it brings in politics, it brings in sociology, anthropology. It's not just a limited biomedical view that's always going to blame the patient. It really looks at these different systems and structures over time that were never in our favor. And so cultural rigor is that arc that allows me to bridge what's happening in the body through history, by looking at things as a Black feminist, through reproductive justice, through research justice, to get me to the right, which is I'm going to look at the Black birthing patient experience through the words, the expectations, the expressions of Black women and birthing people. And those circles around that Black experience are the patient-defined quality domains of birthing in a hospital. Black women were looking for safety and accountability. They were looking for autonomy. They were looking for communication, information exchange. They were looking for behaviors that were anti-Black, excuse me, behaviors that negated anti-Black racism or anti-misogynoir. They were looking for empathy and humanity. They were looking for dignity and Blackness and holistic care. And they were also looking for the relationships that they have with their baby, their partner, their parents, their doula, their midwife, their loved ones. They wanted the system to acknowledge, involve, activate, amplify the social or the the social and the chosen or the biological and given relationships, and how Black women leverage their kin in the hospital setting to get those other circles around that, around their care. So obstetric racism looks at two things. It looks at medical racism. So on this slide, we see that medical racism is really the systems or response or interpretation of a patient's race, right? And let's go around the circle. And then how that response leads to a racialized prejudice or discrimination in language or behavior. And then that impacts the medical care, provision, treatment, diagnosis, and decision-making, and ultimately leads to a missed, delayed, inappropriate, or harmful care and or complications. That is medical racism. And all of that then creates this milieu of new or worsening social or clinical health inequities that unfairly, uniquely, and disproportionately impact Black communities, Indigenous communities, or communities of color. So then let's move to the obstetric violence, because then we're going to merge the two to get to Donna Ian Davis's obstetric racism. So obstetric violence is the hospital's personnel or the workforce responds to women or a person who is pregnant, and how the health professionals' language or behavior in the care provision, the diagnosis, the treatment, the decision-making exerts reproductive control or dominance over the woman or person with capacity for pregnancy or childbirth. And again, how all of that then leads to a loss of patient autonomy, safety, and dignity among women or people with the capacity for any pregnancy-related experience or condition while seeking help or health care. So then we get to obstetric racism, It was first defined by Dr. Donna Davis here on the left in December 2018. And she defines obstetric racism as the beliefs and practices. So again, beliefs, but also in practices. Bias is important, but it's really behavior that's even more important because that's what we can hold people accountable to. I'm not here to change your belief or your values or your morals, but we do need to hold you accountable for your behavior if you are a licensed healthcare professional in this country. So obstetric racism describes the beliefs and practices used by hospital personnel against the reproducing Black body that sits at the intersection of obstetric violence and medical racism, which I defined for you. Obstetric violence, again, describes that situation, right? You're exerting reproductive control or dominance. Medical racism is when the system is responding to a person's race and influencing care that may actually not be appropriate or necessary or optimal. So obstetric racism, right, describes these practices, these protocols, these procedures and policies that are based on racial hierarchies of human value that track along histories of anti-Black racism and eugenics. Obstetric racism can manifest in specific ways. There are 6 dimensions that Donna described, which are here on the screen. Diagnostic lapses, neglect, dismissiveness, or disrespect, intentionally causing pain, but within that is also the lack of motivation to stop Black suffering and the lack of empathy for Black suffering. There's coercion, medical abuse, and ceremonies of degradation. Dr. Davis also describes 3 responses to obstetric racism called refusal, resistance, and racial reconnaissance. So going back to now this definition of sacred birth, right? How do we get to a sacred birth? Well, one of the ways is accountability, but we have to be able to create an evaluation of the healthcare system that truly reflects what the system is doing, not its intention, which is being safe, but its actual impact, which is the feeling safe. And the way to get to that is actually relying on the lived experiences of Black mothers and birthing people. Here's another narrative of a Black woman who participated in my validation of the instrument that I did in 2020, right during year round of the pandemic.
Thank you for this meaningful study. Although I was stressed out due to delivering at the peak of COVID-19 in New York, I strongly believe that my experiences were better than most other Black women delivering at the same time, simply due to my profession as a pediatrician. I was able to call in many of my friends who were Black OBGYNs working in the hospital to oversee my care, and they helped me tremendously. It is very unfortunate that my connections and profession afforded me with these opportunities, despite the fact that overall it was quite traumatic due to the pandemic. I pray that the system changes for the better to accommodate all Black birthing bodies so everyone receives similar special care and attention, regardless of their career paths and internal connections.
So what I was able to accomplish with about 1,100 Black women as patient, community, and content experts was the translation of Donna's theory and analytic and phenomenon called obstetric racism, which is to the left. We translated that theory of describing these harms, right, into a practice of evaluating the harm. So that circle in the middle, the circle around the Black patient, those are the patient-defined and driven quality domains for birthing in a hospital setting. When you look at those, which I read aloud in a previous slide, I want you to look at those domains on this slide, and I'm going to read aloud the domains of quality defined by the Institute of Medicine, now called the National Academy of Medicine. There are 6 domains of quality. They have, and I hope I remember them right now. So there is person-centered, timeliness, effectiveness, efficiency, and why am I blanking on the other 2? That's horrible. I am so sorry. But even out of those 4, none of those 4 domains defined by the National Academy of Medicine actually align exactly with what Black women are saying. There's no kinship that's in the quality domain. There's no dignity. Accountability is not even in those 6 domains of quality defined by the National Academy of Medicine. So again, Though something is standardized and it's right, doesn't mean that it's just, doesn't mean that it is actually true or accurate as it relates to the impact on the patient experience. And it's very important that we listen to, believe, trust, and respond to what Black mothers are saying. Because in 2019, when I did the focus groups, and some people could believe that obstetric racism is not an appropriate term or it's too harsh. Like, for example, my colleagues in the AJOG, the American Journal of Obstetrics and Gynecology, released a commentary saying obstetric violence is a misnomer, that it's too harsh. Well, here's a quote from a Black mother that will remind you of slavery. And she did not know about Donna Davis's analytic. You push out the baby and then you go back on the fields and you keep picking cotton. That is how that Black mother feels giving birth in a hospital. So for AJOG to release an article that says obstetric violence is a misnomer, I can only imagine how they would judge obstetric racism. But then that means they would dismiss, deny, right, degrade, undermine the testimony of this Black mother, right, which is testimonial injustice, but also all the Black women who shared their stories with me, which would be hermeneutical injustice, right? So it's the actual system that's taking a part in the cover-up of true quality and safety in hospital settings. This is an article about, this is the psychometric validation that we published in 2022, in the left in the Birth Journal. And then on the right is a graphic of us describing how we ended up with 806 Black mothers in the study, representing 348 hospitals across the country that represented 34 states plus DC. And it's important to note that the scale represents the patient reported experience measure of obstetrical racism, also known as the PREM-OB scale. It is the first and only validated instrument to evaluate quality defined exclusively by Black mothers and birthing people when the harm is obstetric racism. And we found that each score across those three domains of kinship, humanity, and racism, that those scores of harm did not vary based on individual characteristics like BMI or being fatter, like pregnancy age, preterm birth, like the mode of delivery, having a vaginal birth. So this instrument is showing that independent of positive outcomes, traditional hospital performance indicators, Black women in this country are still experiencing harm when harm is defined as obstetric racism and not as simply the absence of a physical injury or having a vaginal birth. This is the scale. Again, it's organized into three, it's a suite of three scales: humanity, which is, again, remember that circle around the Black mother: safety, accountability, autonomy, communication, and empathy. And then there's kinship, right? The hospital's recognition of the involvement of the social relationships between Black mothers and birthing people and their child or their support system. And then racism, we look at anti-Black racism, we look at anti-Black gender racism or misogynoir. I am on a campaign for obstetric racism to be recognized as a never event. And a never event is this shocking, horrific thing that can happen, but it should never happen, but it does, like wrong site injury or a retained laparotomy sponge. We need for obstetric violence and obstetric racism to be endorsed by these systems as never events. On the right, you'll see a list of other acceptable never events. But why isn't obstetric violence and obstetric racism a never event? So when we look back to my scale, when we look at those scores of humanity, kinship, and racism, there were a couple of questions that I asked Black mothers to kind of get a sense of the relationship between a particular experience and the experiences of obstetric racism. So on the right, you'll see a particular kind of either desire, expectation, or experience. And then on the left, I'll show you how that desire, expectation, or experience is related to kinship, humanity, and racism. So the statement, I wish I had more information and support about lactation, breastfeeding, or chest feeding that was specific to Black mothers and birthing people. Any Black mother or birthing person in that 806 from my 2020 validation study, any of those patients if they agreed or strongly agreed with this statement, wanting more information about culturally congruent, affirming, right, breast body chest feeding, if they wanted more information and support, which means they didn't get it or didn't get enough, they were 2 to 2.5 more times likely to experience anti-Black racism, misogynoir, disrupted kinship, and dehumanization. Let's keep going. Statement on the right. I would seek out a Black physician, midwife, doula, lactation educator, or nurse to be part of my hospital team if I could redo my hospital birth, my 2020 hospital birth. Any Black mother or birthing person out of the 806 that agreed with this statement, they were 3 times more likely to experience anti-Black racism, misogynoir, disrupted kinship, dehumanization. Similarly, the hospital made me feel that because my baby and I survived birth, my experience in labor, birth, and postpartum did not matter. This one is very powerful. Any of the 806 Black mothers and birthing people that agreed with the fact that the hospital made them feel that survival was the goal, right? Positive outcomes, they were 6 times more likely to experience anti-Black racism, misogynoir, 6 times more likely to experience disrupted kinship, and over 8 times more likely to experience dehumanization. That is why survival cannot be conflated with safety, because if survival is our only goal, we're already harming Black mothers and birthing people in the most horrific ways. Here's another statement. I felt hospital staff were available and paid attention to me when I needed help. If any of the 806 Black mothers and birthing people agreed with this statement, they were less likely to experience hospital acts of obstetric racism. If you felt the hospital was available and paid attention to you when you needed help, you were 87% less likely to experience anti-Black racism, misogynoir. You were 90% less likely to experience disrupted kinship. You were almost 100% less likely to experience dehumanization. But remember, safety in this country, right, is the absence of physical injury. It's not these 3 things on here, right, that are the reported experience of the group of people experiencing the greatest burden of death and near death in our country around pregnancy and childbirth. Here is a story. I want you to hear this story. I'm not going to go through the full analysis because of time. I may go through some of the analysis, but what the scale can do is that we can gather stories, and then any text, whether it be a provider, a patient, a community member, a legislator, a lawyer, right? We can analyze this narrative to demonstrate how the presence and permeation of obstetric racism occurs in the birth, is in anyone's narrative about birth.
Overall, I felt I had a positive experience. However, my husband and I felt in the dark at times due to lack of communication regarding our baby while he was in the NICU. We were not permitted to have our doula present due to hospital policy. And as a first time mom, I would have loved to have more explained to me about what to expect. I was upset because my expressed wishes regarding feeding my baby were not implemented. He was given formula and a pacifier without my knowledge or permission, despite my wishes to breastfeed. My husband was reprimanded when going to get water. I believe because he looked intimidating to some hospital staff as a 6'4" Black man. We received rushed and possibly inaccurate discharge information from a staff member who did not seem engaged.
So I do kind of want to go through this analysis. We still have, we have 5 minutes or so, and then we'll stop and have questions. So what I do is that I take a narrative, and just for the purposes of showing you, like in teaching, I color code parts of the text, and then I'm going to show you how, if you'll follow the arrows along as I analyze this text with you, that the color-coded text on the right will be mapped onto the domains and the scale on the left. So we get started. So just follow along and hopefully this will work. Sorry, as I'm trying to move things around so I can see, you can see. Here we go. So we'll start with blue. So the blue text demonstrates violations of two domains. We're going to start with safety and accountability. Based on feeling rushed, dismissed, ignored, neglected, not listened to, and not having their questions, concerns addressed during clinical encounters and interactions. When you think of safety and accountability, think of a violation of love, comfort, confidence, protection. And this is how Black mothers and birthing people define safety and accountability. Next, you see the blue arrow goes to communication and information exchange. This is violated based on explaining, understanding, and exchanging information in the least optimal and equitable manner for the Black mother or birthing person and their kin. When you think of communication and information exchange, think of knowledge and power gatekeepers, again, as defined by Black mothers and birthing people. Now we're moving back to safety and accountability, but we're on the yellow text. So in this example, we see a violation of the right to the active presence and participation of a patient's chosen advocate throughout labor, birth, and postpartum. This violation of safety, as defined right by the feelings and thoughts of Black mothers and birthing people, was violated numerous times during the pandemic. Now, I'm not saying that there wasn't just cause, right? We were trying to mitigate COVID-19, but those mitigation strategies lacked humanity, right? And so for Black women and birthing people, they felt their safety was violated when they didn't have anyone there with them to defend them, right? To ensure accountability to their quality and safety. We're still on the yellow. Now we've gone to autonomy and what I now call kinship instead of social networks. Violation of patient agency and the need for advocacy by excluding their doula with no consideration for the financial implications to the family and doula based on their agreement. So we're doing things in a hospital setting in isolation where we're not really in isolation. We're all in some relational capacity. There's some power differential relations happening. So again, those policies that were enacted did not take in consideration agreements and trust between the doula and the patient and family. We're still on communication information exchange and on yellow. Based on explaining, understanding, and exchanging information, again, in the least optimal and equitable manner for the Black mother, birth, and person, the hospital exploited, again, the power differential as knowledge gatekeepers. Sounds like epistemic, right? Redlining. This happens a lot. Now we're in the red, still on communication information exchange. In this example, we see that, oh, I'm sorry, I have to get it together. We see that they're not feeling seen, heard, listened to, believed in, and comforted. Still on the red, we now go to autonomy and kinship. Now, this is violated based on the delay or denial of the express plan of care around the infant feeding. In this case, the Black mother desired body, breast, chest feeding over formula. The hospital denied informed consent and refusal and violated the vision of how a Black mother wanted to nurture and nourish her child, violating kinship between Black mother and newborn baby, as if both are chattel property of the state, and affects how the Black mother desired, and affects how the Black mother's desires to care and to nourish her child was taken away from her. It wasn't acknowledged, it wasn't fulfilled. In isolation, that may mean nothing to you all. But when you historicize that, that is what happens, right? Happened in child slavery, the forced separation of Black mother and child. There's something ancestral cellular that people are experiencing, right? When these things happen in the hospital, independent of intent or hospitals wanting to be safe, they're in fact causing people to feel very unsafe. In the safety and accountability, still in the red, based on violations of autonomy, kinship, and communication, resulting in violations of social, mental, emotional, and cultural safety, and the absence of consequences for the actions of the clinician, staff, or health system. Now we're on the green. The green represents 2 violations and 1 amplification. We'll start with racism as being amplified in the situation. Racism is affirmed and amplified by the perpetuation of a racist stereotype about Black people in general and Black mothers and birthing communities in particular, held by hospital clinicians, administrators, and staff, in public or private, that adversely impacts the provision of hospital-based care, support, and services. Black mothers and birthing people also discuss the ways in which Black men or masculine-presenting partners and loved ones modified their behavior, attitude, language, and or appearance when wanting um, when wanting to advocate for their family. They changed the way they would be perceived, right? So that they would be more palpable to the staff, right? So there's this way in which the hospital, I call it the hospital stop and frisk, where the hospital was essentially conforming to the historical and contemporary stereotype of Black men as a Black brute or animal like savage, for feeling threatened by him walking in the hospital, when if he hadn't been in the hospital, right, they would have said something about her, like, where's your baby daddy? Which we have reports of Black mothers saying gets asked of them all the time, right? So being present or being absent, the goalpost gets moved, because it's not about either or, it's about treating us like we're subhuman and non-human. And so we're now in the green. I think we're in the green. Yes, we're in the green. So with the green, still we're talking about kinship, right? This weaponization of race, gender, height, and white fear that leads to medical brutality, racial profiling, again, that hospital stop and frisk. With safety, again, we have the exclusion and separation of partners, especially Black men, from participating in the care, communication, the interactions, the decision-making, which leads to decreased perception and experience of safety and trust for Black mothers and birthing people when their partners or loved ones are excluded or removed from care. This also leads to increased medical violence, surveillance, brutality against Black men during birth, that can lead to a disproportionate overuse or inappropriate use of security, psych, child protective services, law enforcement, all those things happening in a space where we're supposed to be celebrating birth, right? And then lastly, all the purple. So we continue to have a violation of safety, right? Feeling rushed, dismissed, ignored, neglected. We have ongoing violations of communication and information, especially when those stats that I shared before, right? 84% of the deaths are preventable. 53% of the deaths are occurring after people leave the hospital. So communicating and exchanging information is so crucial during a birth in a hospital setting. Something is clearly missing, because people are actually dying after they give birth at greater rates than before they give birth. And lastly is the empathy and humanity. These behaviors in isolation, people may dismiss, but in contextualizing it through the experiences of the patient and their partner and their community, we see behaviors from the hospital as being harsh, as being hostile. There's a lack of compassion, right, for the birth expectations and experiences of Black folks. So here's the other way. So that was one way to have a narrative analyzed through the tool, the domains in my tool. This is the other way, which may be a little confusing, but I will explain. We generate scores. These scores for each domain can be, if you know what a bell curve is, it can be essentially like the shape of a bell, where at the peak, at the height, is the mean in the middle. So here on the slide, there's this red bar up and down vertical called sacred birth. That's given a 0 because that represents the mean score of kinship for the 806 people that were in my study in 2020. Anything to the left, you see this arrow, anything less than 0 gets a minus sign. Left means less. Any bar that has letters on it represents a hospital. So anyone that's to the left of 0, to the left of sacred birth, they experience less obstetric racism. Anyone to the right of 0, to the right of the mean where sacred birth is in the center, mean means, to the right means more. So this is an example of the kinship, right? That story that I just shared. This is an example of kinship as a hospital performance indicator. So in this scenario here, the best performing hospital that has the lowest kinship score are 2 safety net hospitals. And this is from San Francisco County. If you know San Francisco, you know there's a really prominent, well-known academic center there. That's where that center is. It's to the right of 0. To the right of that is a private hospital. To the right, far right of that is another private hospital. In San Francisco County, the academic and private hospitals disrupted kinship more than the county average for these 5 hospitals, more than the 2 safety net hospitals here. And that's important. So this is an example of how using kinship as a patient-defined quality domain can be used to evaluate the safety of care and evaluate to hopefully help insurance companies around reimbursement, right? Why are we paying for people's harm? We just need a better instrument to hold people accountable. This is a paper that shows again, This is a paper that shows how in the presence of a support person who was not affiliated or aligned with the hospital decreases, right, your experiences of obstetric racism across all 3 categories. We also found that even when somebody was married or had a partner, marriage or partnership, which single Black mothers are judged by the hospital, in this work, marriage or partnership did not sufficiently mitigate obstetric racism. It's really about the physical presence of someone who's fully committed to keeping you safer from the hospital as a strategy, as opposed to marriage and partnership. So one of the things that we can begin to do is this built-in system where we either have an in-person or virtual birth safety team of a community support person who's not affiliated or aligned with the hospital. We can assign them different roles. They can be the emotional support person. They can be the active bystander. They can be the note taker, the meal snack prep person, the music playlist, get the movie TV shows going, aromatherapy. But these are all the ways that the consumer patient client community can resist, right, hospital acts of obstetric racism. This is just another way of resistance. We talked about in one of these papers, destigmatizing, democratizing postpartum care, because again, 53% of pregnancy-related deaths are occurring in the postpartum period. So we designed this framework with this beautiful image, building and bridging Black futures beyond birth, a 12-step Black woman person first approach to optimizing postpartum care. So we have, the saying, you are more than one day of care. Because right now, people used to say you just need a 6 weeks postpartum visit. You're worth more than one day of care. Also, we wanted to engage the community. So instead of focusing on the pathology, the risk, the disease mitigation, stratification, disease management, let's talk about the Black body, the Black person and their child and their family, their community as a whole, and how they're navigating all of these things that could potentially happen in the postpartum period. And let's use shared language that the community can partake in if we build their capacity to be on watch, right, for the safety of the postpartum person. Instead of saying, look for scotomata or blurry vision or a headache, right, medical terms, let's talk about brand. Like, girl, what's your hair look like? Are your nails done? What's your makeup like? What's your beauty like, right? The brand and beauty, how do you feel? Or do you feel that you can glow? Let's start in a humanizing way and then work our way through. So you'll see we talk about brand, beauty, blues, blood pressure, breathing, breast, chest, bonding, boundaries, belly, bleeding bones, and a Black bag. This is a more humane, just, participatory way to engage the community around looking out for each other that then we could relate back to the health system. But we have to move beyond pathology, right? And engaging the community around safety. We want to make sure patients know that they have a right to access their records, right, with the 21st Century Cures Act and the HIPAA access right. Another way that we are building resistance with community is that we support people to file a complaint to the Office of Civil Rights and anyone can file the complaint. But this is another way to hold hospitals accountable. There were 26 of us, a part of a movement with Elephant Circle, where we wrote a legal memo mobilizing the Office for Civil Rights Authority to address obstetric violence and obstetric racism. I am more than happy to leave that with the Tennessee Justice Center so that you could also read that memo. And basically all these things, right? Just starting with don't leave the 98 behind, right? The absence of perinatal pathology is not the presence of perinatal equity, right? And that safety is much more than the absence of physical injury or reducing adverse outcomes. Safety in our community is about an emancipated birth. It's about being trauma-informed, pleasure-focused, spiritual, inclusive, radical, power-activating, liberating, participatory. Obstetrical racism violates this, but if we don't change the way we define safety, we're never going to be able to make the experience of birthing in a hospital whole. Thank you, and we're open for questions.
Yes, so thank you so much, Dr. Scott. Such great information. And if anybody has any questions at this time, feel free to throw them in the chat, in the Q&A box. You can throw your hand up and we can unmute you. So yeah, and first we have a request. Can we just reshare and leave the
Yes.
contact screen up?
I'm sorry, that's me being all like, let me take it down. Yes, I promise I'll put it back, right? That's why I made the slide. Thank you for reminding me. Oh, did I take it away? I'm sorry. Let me stop pressing buttons. Here we go. And I want to make sure people know I'm back home. I'm in Nashville. So, you can ask questions today. You could also invite me to wherever you are to talk to your teams, your community. I'm back home in Nashville.
And if I may, I'm just going to, while we're waiting for anybody that has any questions, I just want to throw out there that when we reached out to Dr. Scott, it was somewhat disheartening that she told us we were the first Tennessee group to reach out to her. And so if we have anybody else from Tennessee here who really wants to get involved with this, I'm sure Dr. Scott would love to have more people in her home state here, whether you're in Nashville, across the state, to really get involved and help. So we want to make sure that she is, able to do her work here in her home state as well. So, all right, I've got a couple things that popped up in here. We'll just kind of start with that first one there.
Excuse me.
I don't know if you can see these questions as well, Dr. Scott, or not, but
I can.
I think Sabrina says, how do we move forward to protect Black mothers?
Yes. Hi, Dr. Vitti. So all the things that I listed, right? Like I think there are multiple ways that we can protect Black mothers, right? In real time, and then right as we prepare. So in real time, that slide that listed like having people serve different roles, because what we are, hopefully I conveyed that what we are dealing with really is a human rights violation, right? So when we contextualize quality and safety within a human rights framework, then we do need to have these different roles for people when they go into the hospital setting. Even for myself, when I not pregnant during COVID, I had long COVID. I actually had to get my actual midwife on the phone she's a midwife. She's the director of midwifery at the General in San Francisco, Ana Delgado. And then my friend Jessica Roach, who's a doula, they played my COVID doulas for me as a physician to keep me from experiencing misogynoir in the health system. And so if our communities of Black mothers and birthing people do not have access to a doula or cannot pay for the doula, at minimum, if we have a smartphone, get someone on the phone to just be there. Because some people are at home, they're at work. Like I have done that as well, where I'm like, just call me when you get to the hospital, so that there's a witness. And it's sad to say that, but that we have to bear witness for our community. I'm also recommending people the same way there's a chart, right, that we use, right? We write the time, the date, all of that. I think that people need to also start keeping a record, because right now the health record is not on our side. When I say our side, on the side of the patient, it's on the side of the system. So keeping a record of names and contacts, not to be like litigious, so that we're going to sue, but we need to hold people accountable, because there is, there are ways in which people can change the record or write a narrative in the health record that favors the system. I think that, like, some of the questions around like breastfeeding, if a hospital doesn't have a Black lactation consultant, my friend Tonifer Kamara, who's a IPCLC and a womb healer in California, the song Teach Me How to Dougie, she basically said, teach me how to breastfeed. You can look on YouTube right now. There are ways that we can leverage technology. And I don't mean like AI, literally like our phones, the YouTube, the TV that's in the hospital room. There are Black doctors right now with podcasts. I think of Dr. Joy Cooper. I'm blanking on, I think it's Nicole Blank in Virginia. There are ways we can bring some racial gender concordance into the birth space, so that people don't feel as isolated, but also it's a way for them to see how this is what a model behavior could be from a provider that I'm watching on the screen around pregnancy. If my team is not aligning with that, then now I know. Long-term policy, like I started to write, we have a draft bill for the state of New Jersey, but of mandating obstetric racism be measured in a state, because we have more power, honestly, as states than we do at the federal level. And I'm giggling because if we could get, I don't know about Tennessee, but other states, things at the state or the county level, right, where hospitals have some accountability towards, obstetric racism, obstetric violence should be a never event. They should be hospital performance improvement indicators. We should, like, all Medicaid births should be implementing this scale. I could keep going on, but those are some of the things that I think. And also, practically as an OB, we need to be making space for midwives to be in the space with us. The numbers of interventions reduce dramatically when we have midwives in the space. I trained in Chicago, where my chair was the midwife collaborator of the largest midwifery group in Chicago. So yeah, I don't break the bed down. I sit in the bed there. I'm a midwiferized OB because my chair and my residency program director were MD collaborators with midwives, and that changes everything. So I could keep going, but yes, I think we need to have different models of care. It should not be OB first. It really should be midwife first. But I'll stop on that tangent, because I think that answers another question that Destiny Rosado. Yes, I am a firm believer in what I'm saying now, that we need a different model of care. Is it the UK or Sweden? Like, they start with the midwife first, and then you get we're interventionalists. Like, I'm a surgeon. I was trained to be um, I was trained to intervene. I was not trained well, I'm saying I, as the globally OBGYNs, I trained in a community hospital where I know what physiological birth is. So we were trained that if someone ended up having a medical complication during their labor, birth, and postpartum, we only manage the medical complication. So people at the hospital where I trained could still have medical complications and be supported through a vaginal birth with a midwife while we manage the medical complications. So I don't know when that switcheroo occurred nationally, but I think that is part of the problem. Does that answer some of the questions that are in the chat?
Yeah, and so I think you did a good job there. And I've got the next one, I think is a really important question as well. How can we support efforts to have insurance companies try to
Oh,
push the Prim OB into hospitals and have reimbursements tied to the scores?
yes, these are my peeps. Hi, Dr. Felicia Castillo. So all CMS, everybody, we need to contact, even in our state, like I'm gonna probably get in trouble. I've contacted Blue Cross Blue Shield in our state in 2021 before I even moved here. A couple of things I've learned about insurance companies, I don't know if you all are aware, but there's a maternal child health group, there's like a health equity group. When I say group, like their teams, there's a maternal child health team, possibly a health equity team, and like a measurement team. Did you all know they all don't talk to each other? So Dr. Castillo, what I've found is that I'm light years ahead of people where I've created a scale that brought in health equity, measurement, data science, and maternal and child health. Most of those teams don't work together. So part of it is that I don't know if even the insurance companies are at the have the capacity and readiness to hmm, to deprioritize claims data, right? Every diagnosis and procedure gets a number, a CPT code or ICD-10 diagnosis, and those numbers are what get turned into insurance companies, which then determines reimbursement. And those numbers can also represent like levels of care, higher level, in theory, more reimbursement. We need to mandate, right, an expansion on how we evaluate quality, and that for the value-based care mechanisms, like the models of care and those mechanisms of reimbursement, value-based care really should be determined by experience plus outcome, not just an outcome. Because as we've seen, if we focus only on outcomes, we're going to get a myopic view of safety. So therefore, that value of that, right, there's going to be a false sense of value for those services because we focus only on the outcome. So we need insurance companies to expand their notions of not only safety and value to include experience measures like the Promoby scale, and then just set it as a goal, like all of the reducing the cesarean birth rate, right? The NSTB rate that all these insurance companies are doing, it hasn't done anything because it wasn't ever about the C-section. It's about the experience of care that Black mothers are having. It's about the dismissiveness that occurs, right? It's all those things. It's not just the act of taking somebody to the cesarean room. What are all the things that happen before getting to the cesarean? And we're not naming obstetric racism as a problem. I could keep going on a rant with that, but yeah. I need for y'all to start like contacting Aetna and where are all the ones, United Care, HCA, all the people, and say that we need different standards of different measurement standards, and we need to make experience be the outcome, and not to only promote the Promote B scale, but there are other experience measures. Like that's what we really need to be doing, in my humble opinion. Oh, someone asked about the, the definite other because there are considerable differences in the definition of maternal mortality ratio. Does this create problems with accurate data representation? Yes. I mean, yes. Any time we have variations in the definition of a phenomenon that we're measuring, we're going to have variations, right? And its frequency, right? And its distribution. This is the epi and me talking. So yes. And the other part is, though we honor, right, the ancestors who've gone on because of, I'm going to be blatant, being murdered by the hospital, I believe the ratio is that for every one death, there's 100 missed deaths. So unfortunately, the prioritization of the deaths excludes the 100 plus people that almost died, because it's the lived experience of people who almost died. They got all the secrets, they got the juice because they survived. And I don't mean survive like make survival the goal. I mean, the survivors know who harmed them. Those who passed on can't tell us what happened to them and who did it and how. And I think that's part of the lure, the benefit of putting so much emphasis on those who died, in terms of, I'm talking about like the data people, the hospitals, where in the community we grieve their presence, their absence in our community. But there's so many people who almost died that we have silenced them, or we're silencing them, or we've made them silent. There's very few studies that look at those who almost survived and what happened to them. We can learn a whole lot. Hi, Jesse. I know, right? How do we get people to understand that the absence of pathology is not I mean, I keep saying that. I don't know. I don't know. Am I the only one that tells you all this? Because I realized it in me, right? In me growing in my own scholarship. I was like, aha, it was a light bulb moment for me that all of the investments in reducing outcomes meant that people believe the absence of adversity in terms of an outcome was equity, was safety, right? Was being anti-racist. And it's not. And so I need like BCR, Birthing Culture Rigor, Dr. Scott needs like disciples, needs ambassadors to keep spreading this word and referring people back honestly to my work. 'Cause I don't know if anyone else is sharing that insight to help people like truly, like to critically reflect on the strategies that they're promoting to see if that actually will change harm when harm is defined by an experience and not by an outcome. I don't know what else to do, but continue to be invited to talks, continue to amplify the community, right? And their voices, and not just getting the community to tell their stories, but what I also say is translating their stories into scores, into performance scores, but you can do that with the Promobi scale, and then transforming the score into a strategy. Like there's a disconnect. There's all of this, let's listen, which we absolutely need to listen. But we need to move towards translation, right? We need to move towards the story into some performance indicator into a strategy. We are stuck on almost at the other word, which I'm not going to say, STUPID, that other S. We can't just listen and we like applaud ourselves. What is the translation of that story into a strategy to hold a system accountable? Hi, Dr. Diane. Hi, everybody. It's Berg. Yes. So please, if you can drop my name in special places, that would be awesome, because I feel sometimes that because I'm speaking this type of truth, I'm sure that it's quite intimidating, but it's the truth. I mean, I believe if we could think about safety in this way, we could hold people accountable.
All right. Well, and thank you so much again, Dr. Scott. And unfortunately, we just want to be respectful of everybody's time. So I know you've got your contact information up there. I'm sure if anybody else has other questions, you're more than happy for them to reach out to you.
Yes.
Continue this discussion online. And so I just want to thank you again so much. And I'm going to turn it back over to Chandra and let her finish up for us here. So.
Thank you so much, Nick, for helping to facilitate tonight's discussion. And more importantly, Nick, for connecting TJC to Dr. Scott. Thank you so much. And to find out that we had this gym right in our own neighborhood. So thank you so much, Nick. And thank you, Dr. Scott, for this eye-opening presentation, and also for the courageous work that you are doing um, to make sure that obstetric racism is a never event, not just in Tennessee, but across the country. And also for just reminding and affirming for some that surviving childbirth should not be the goal. The goal that, and further, that safety cannot continue to be measured by whether or not there's physical harm. And thank you to everybody who has participated tonight. And this brings me to why we're here. So TJC joined Black Health Matters to have this conversation tonight during Black Maternal Health Week. And we chose this night, chose this opportunity to share because we know that there are issues in Tennessee that we need to be working on. So who is Black Health Matters CN? So we are Tennesseans from all Black backgrounds who care about injustice and who want to live in a state where all Tennesseans can live full and healthy lives. You know, and folks are asking, so why Black Health Matters? You know, Black Health Matters exists um, for this reason that we see around maternal infant death rates that are twice as high as there are for the general population, higher rates of chronic illness in communities. We also see lower survival rates from treatable diseases like cancer, and overall lower life expectancies among Black people of all ages. And the thing that we know is that these are not disparities that are accidental or genetic, but that they are a legacy of the racist history that has perpetuated these present day practices. And we also know that change won't come until we demand it. For we know that what does they say? Power concedes nothing without a demand. So Black Health Matters is demanding that we, as a group of folks in the state of Tennessee, come together to eradicate the legacy of racism in healthcare, to work collectively to eliminate these disparities that exist, to exterminate policies that perpetuate violence, um, obstetric violence, violence in our communities, violence in our healthcare system. We want to exterminate this, and then to overall to elevate health equity as an urgent priority for Tennesseans. Dr. Scott mentioned that she doesn't know about Tennessee and their practices, but the sad thing about it is that we do know. Um, what it means for vulnerable people to live in a state where the healthcare system is fractured. So we want to invite you all to join us and join the Black Health Matters movement in Tennessee by taking this call of action, signing the Black Health Matters pledge. You can scan the QR code to learn more about Black Health Matters, TN, and the work that we're doing, and more importantly, to join us and be a part of the work that we're doing. So again, we thank you for joining us tonight. Dr. Scott, I am looking forward to the conversation after this conversation because I have got to learn more. And again, thank you all for participating and taking time out on this evening to join us. And we hope that you'll join us again. Just a reminder for folks that ask, you will receive a copy of this recording in an email for everybody that registered for the webinar. So again, thank you again and have a great night, everybody.
Thank you, everybody. Bye-bye.